Good morning. So, it's almost every time it may be a boon to treat the disc prolapse, and at times it's a bane for the spine care professionals. I will brush upon the etiology, the treatment modalities, the future, and a few questions which you would ask in this short period. Here are a few examples of disc prolapse. With severe disc prolapse, you can see the disc bulging out and compressing the nerve root there. This is the removed fragment. So the intervertebral disc is a complex structure with gelatinous nucleus material contained with the annulus. The annulus has cartilaginous and collagenous parts, and it is attached to the anterior longitudinal ligament, the posterior longitudinal ligament, and the vertebral end plates above and below with collagenous material. So what leads to the degeneration and the problems? For that, we need to know about the vascularity of the disc. The nutrition of the disc is the problem. So by the first year, at birth there are a few vessels supplying the disc, and by the end of first year these vessels recede, and there are hardly any blood supply to the disc. The adult disc is almost a vascular structure. As years go by, there is the decrease in proteoglycan content of the disc, and that will lead to fissuring of the disc as well as ingrowth of cells into the disc. There are few nuclear cells and annular cells in the adult disc, and the blood circulation to this disc is impaired. That will lead to the degeneration, and it may be because of the disc cells get nutrition by diffusion from the adjacent vertebral body, which are richly supplied with blood. As the height of the disc increases, the chance of the inner part of the disc getting nutrition is less. And if you load the disc continuously, the chance of diffusion is much less. The accumulation of waste products in the disc, that will lead to degeneration. And there are a lot of genetic factors as well, because the production of abnormal proteins and the end plate, that will lead to impaired nutrition to the disc. So nutrition is the key factor for degeneration of the disc. So now the symptomatology, depending on the site of prolapse. There may be axial, neck pain, back pain, radicular pain, and the neurological deficit depending on the site of prolapse. For example, it may be the patients may present with quadriparesis, with the myelomalacia and a severe disc prolapse in the cervical region. Or it may be Cauda equina syndrome with the gluteal ulcer and bowel bladder incontinence and paraplegia. So the management, we have to classify into acute backache or neck pain and chronic back pain and neck pain. The acute pain, arbitrarily we can classify into those occurring within 6 weeks. It is at most importance to treat this acute back pain effectively so that the brain doesn't get sensitized and the patient go on for a chronic back pain. There are a lot of pharmaceutical agents, so many specialties dealing with this disc problem, and osteopathy and physiotherapy, all these. So we all advise the patients differently, and they will obviously go for window shopping, and it is very difficult to point out which is the ideal treatment. For acute disc prolapse, as I have told, the intermittent loading is better for the health of the or nutrition of the disc. If you load your spine intermittently, compressive loading is better for nutrition of the disc. So it's better not to keep the patients for a prolonged bed rest. In acute disc prolapse, you can 2 or 3 days bed rest followed by active mobilization is better than keeping them in bed. NSAIDs, there are evidence that it is better than placebos, but it is almost equivalent to acetaminophen. Complementary therapies, massage therapy, acupuncture, exercise, all these can be done, and we should be careful about using NSAIDs injudiciously for the renal, cardiovascular and GIT side effects. In acute disc prolapse, we can use muscle relaxants, but not in chronic disc prolapse. It's more of there is a central sensitization imparted to the chronic chronic back pain or neck pain. So for them, antidepressants, lumbar supports and Tramadol will help in chronic back pain, but not in acute back pain. And in chronic back pain or neck pain, Tramadol plus paracetamol is an effective combination because it reduces the central sensitization, and is recommended by the ULR for long-term usage. And a few words about spinal manipulation. Recently, the Journal of Musculoskeletal Disorders, it is reported that if the massage is associated with an audible click, that will attenuate the stretch reflexes and the muscle spindles. So there is reduction of pain with spinal manipulation if it is done properly within the trained hand. And the indications for surgery are the primary indication is persistence of pain, and then the failure of conservative treatment, increasing neurological deficit, cervical myelopathy, and a lot of options for surgical treatment, interlaminar, intradiscal, posterolateral, all these. And it's hard to know which is the best one. But there are studies that I will show you at the end of the deliberation. And plasma disc decompression, and the clinical success rate reported is endoscopic discectomy, the success rate is about 80%, and interlaminar approach is the best one, 85 to 90%. This is an example of a sequestrated disc. This was the fragment. Again, another sequestration. So the option is minimally invasive lumbar discectomy or micro-discectomy. You can mark the level with a needle with a CM, then elevate the paraspinals on one side, to which side it is prolapsed, then cut the ligamentum flavum, and if at all needed in the higher level, you may need to nibble off a little bit of bone if needed and take out the disc. And in cervical disc disease also, they may present with neurogenic claudication at times, like this case. Or there may be instability, as the natural history of the disc disease goes, dysfunction, instability and stabilization. There may be canal stenosis and secondary problems. And in cervical myelopathy, expansive laminaplasty or laminectomy in a lordotic spine or with a stabilization is an option. And most of them, if it is done within a year of occurrence, they may become walkers, but the finer movements may be impaired. Thoracic disc disease is very rare. You may have to address anteriorly by thoraco-abdominal approach. And the complications mostly may be a wrong level, dural tear and so many. And the routine lumbar discectomy doesn't need fusion. But if the patient is presenting with back pain and no radicular pain, and if the patient has mechanical back pain prior to the episode of disc herniation, and if this pain is worse with extension, a fusion will be better. And prosthetic disc replacement, there are so many complications reported, and long-term reliability, safety and clinical efficacy are under study. So the approach is, first rule out Cauda equina syndrome, progressive deficit, risk factors for METs and abscess. If there is nothing, then conservative treatment for about 4 to 6 weeks. And if there is no improvement, go with further investigation. If it is a compressive lesion, do surgical, and if it is non-compressive, medical treatment. And the future, obviously there are, with all diseases, there is gene therapy is an in thing, and maybe in the future it will come up. And stem cells, of course we can transplant stem cells into the disc space, but the main pathology is the lack of blood supply. So that is not addressed so far. So it is under study again. And another possibility is allograft transplantation with good results. But who will give the disc for transplantation? That's another question. So motion is lotion, stay active as possible, and there is no gold standard for treatment of classification of low back pain or neck pain. And there are a few queries you might ask me at the end. So I'll tell you early before that. With this, is there any difference between percutaneous tubular discectomy and microdiscectomy? That's a routine procedures. This is a report in the European Spine Journal in 2011. A randomized control trial with CPK monitoring and the cross-sectional area of the multifidus muscle. The before and 1 day after surgery the CPK and 1 year after the muscle cross-section by MR. The conclusion was tubular discectomy compared with conventional microdiscectomy did not result in reduced muscle injury. Postoperative evaluation of CPK and the multifidus muscle showed similar results in both groups. Although patients had underwent tubular discectomy, patients who underwent tubular discectomy reported more low back pain during the first year after surgery. And the other question is comparison of minimally invasive procedure and a standard microscopic discectomy. The randomized trial showed both procedures show equal midterm clinical results and same complication rate. And another question is whether transforaminal endoscopic lumbar discectomy is better than conventional microdiscectomy. That's also reported in the European Spine Journal. The reoperation rate was higher for PED with a 6.8 compared to 4.7% for microdiscectomy, and the complication rate also was less for microdiscectomy. The current evidence does not support to show that PED is better than microdiscectomy. About the adjacent segment degeneration, there are a lot of debate on that, but the conclusion so far is the adjacent segment disease is more of a result of the natural history of the disease than the presence of a fusion. And the impact of adjacent level disc degeneration on health status outcome following lumbar spine fusion. But this article says there is no adverse impact on the clinical outcome when the lumbar fusion is ended adjacent to a degenerative motion segment. And of course there are many reports showing that heredity plays a role, and there is genetic influences on the disc degeneration, and the importance of heredity in the development of disc herniation in dogs has been described by Wilsey. So do surgery if surgery can correct the deformity or correct instability or relieves neural decompression.